Hello, welcome to the American Journal of Managed Care Peer Exchange, Technology in Diabetes Care from Prevention to Disease Management. My name is Dr. Dennis Scanlon, and I'm a professor of health policy and administration and director for the Center for Healthcare Policy and Research in the College of Health and Human Development at the Pennsylvania State University. In today's discussion, the panel of experts will discuss the ever-increasing role that technology plays in both preventing and managing diabetes, as well as the challenges for payers, providers, and patients. Before we begin, let me briefly introduce our panelist. Dr. Robert Gabbay is Senior Vice President and Chief Medical Officer of Joslin Diabetes Center in Boston and Associate Professor at the Harvard Medical School. Ann Hodorowicz, a Chicago-based dietitian, certified diabetes educator and consultant to physicians and health systems, and certified endocrinology coder. Dr. Neal Kaufman, founder and chief medical officer for Canary Health, and a board member with the Council for Diabetes Prevention, an adjunct professor of medicine and public health at the University of California, Los Angeles. And finally, Dr. Kenneth Snow, a medical director for Aetna. Thank you all for joining us. So why don't we begin? First, we're going to start with segment one, the rise of technology for diabetes prevention. Bob, maybe I can start with you. We talk a lot about diabetes and diabetes treatment. Today we're going to talk about diabetes prevention. I guess maybe a starting point is, what evidence is there for prevention and whether prevention works?
Well, it's a great question. So really the landmark study was a study from the National Institute of Health, the diabetes prevention program. And what they did was test fundamentally, can you prevent the development of diabetes? And they took two different approaches. One, a lifestyle intervention under very controlled, rigorous conditions, and the other was medication. And the medication initially had two arms. One was a thiazolidinedione that was stopped because of the liver injury. That was with troglitazone back in the day. But the arm that continued was with metformin as a medication to prevent diabetes development. And the remarkable results were that the lifestyle intervention reduced the development of diabetes by almost 2/3, and twice as good as metformin did. And so lifestyle was really very effective. And the challenge of that study was it was done in a very rigorous and resource-intensive way to ensure that people adhered to their lifestyle. And the challenge has been now, how do you apply that to the broader population?
Right, yeah. Anyone else have any thoughts about that? How you take what was done in a controlled setting and work in prevention in the real world?
Well, that's always one of the concerns for a payer, is whether something that has been accomplished in a very well-controlled clinical trial, whether it's actually going to show the same type of results when you bring it out into real-world experience. And certainly with the DPP, I think everybody is hopeful that that is the type of results that we continue to see.
Mm-hmm.
And I'd like to comment about how we define lifestyle intervention. What the trial showed is that weight loss was one of the key factors in the prevention of full-blown type 2 diabetes, 5 to 7% of weight loss from baseline, and then a lower fat eating style and exercise, 150 minutes per week of aerobic exercise, and then some stress management. So those are really the elements of the lifestyle intervention.
So what we found with this theoretical approach, highly resource intense. One individual could maybe help 30 or 40 people over a year. It was 16 weekly sessions, monthly sessions thereafter, an hour each week, one-on-one in person, and that worked. The CDC recognized that that was not a scalable or sustainable model and began looking to how to provide it in other ways. There's really been two streams or two threads of approaches. One, that's the dominant one, which is to use groups. So instead of one-on-one, it was one with 10 or 15 people, highly trained individuals who would provide it. The paradigm for that was done most effectively in the YMCA, where they did a pilot study, then got CMMI funding to do a major study to look at outcomes. The second sort of approach was technological. And the question was, could you take the program delivered in person and provide it in a technological format using internet, cell phone, et cetera? So our company was involved, I was very much involved back in 2006 to create a digital version of that program. At that time, we didn't know if it was going to work. We didn't know if people would accept it, but we recognized that people need choice, that having the ability to take in-person and digital as a way by their choice, it makes perfect sense. And so we and now a number of other companies have been able to demonstrate that you can take an in-person program, use great design and great approaches to make technology work, and have individuals use it effectively.
Great. Yeah, I want to get into that technology piece a little bit more. Before we do, though, you mentioned the YMCA study. And I was wondering if one of you might talk a little bit about that study, sort of expanding from the earlier one that Bob mentioned.
Well, one thing I would like to say about the YMCA study, when I just defined about lifestyle intervention, is that self-monitoring, the patients, the participants self-monitoring their eating, their exercise, their weight loss on a regular basis and reporting that to their lifestyle coach. That element, I think all the physicians would agree, that element of self-monitoring increases motivation and that stick-to-itiveness to keep going with the program.
Mm-hmm. I believe there were also a number of session requirements and some particulars around that as well.
Yeah, so basically the YMCA study, which has then led to part of the regulations and requirements that the CDC puts out, requires 16 weekly sessions. They have to be offered to the person no less than over 16 weeks and no more than 26 weeks. There have to be additional sessions at least once a month. Those sessions have certain content that have to be there. They have to do goal setting, monitoring, tracking, get feedback on it, create action plans of what they're going to do between sessions. And whether it's in person or digital, those same requirements are